Our next speaker is Lawrence Western. He's a board-certified psychiatrist who specializes in the treatment of patients dually diagnosed with addiction and mental disorders. And I had a hard time learning how to pronounce his name, but Carolyn Harden said that I could just call him Dr. Larry. And I don't think y'all need to hear from me anymore, but I'm going to turn it over to Dr. Larry to talk about medically assisted treatment.
Thank you very much. Before I start, I want to thank Garrett on behalf of this audience for what you said. You really underscore the seriousness of what we're here to talk about. The experiences that you've had and that your family has had really tell us what we're here to talk about. You're also a very difficult act to follow. But I do want to say that you brought up a couple of things that we're going to be talking about in my speech today. We're going to be talking about the place of Suboxone. We're going to be talking about the place of peer support groups like AA and NA. We're going to be talking about the different treatment modalities that people need to get better from their addiction. So thank you for your superb words, Garrett. I'll tell you a bit about myself. I'm an addiction psychiatrist. I treat addicted people in New York and New Jersey. I live in New Jersey. My practice has to do with people with alcohol problems, cocaine problems, heroin problems, other opiate problems. I do prescribe Suboxone, but to a relatively small number of patients. So my practice encompasses the full range of people who have addiction and dual diagnosis problems. I understand we have a very diverse audience today. Some of you are from law enforcement, some of you are judges, some of you are attorneys, some of you are clinicians. So I'm going to give a broad talk about medication-assisted treatment today, and I'm going to leave time at the end for questions and discussion. Given the number of people here, we're not going to be able to have every issue answered. I'm going to raise a lot of issues. I'm going to put my contact information up at the end and give you some suggestions for further learning when we stop today. What am I going to talk about today? I'm going to talk about understanding the biological basis of addiction. I'm going to talk about identifying goals for treatment. What are we looking for when we're working with an addicted person? I'm going to talk about the FDA medications that are approved for treatment and a few that aren't. I'm going to talk about understanding the indications for medications used to treat opiate use disorders. Basically, what does a doctor or a clinician look for when they think about prescribing a medication to someone who's got an addiction problem? And I'm going to talk about how we decide on treatment changes and reduce the risk of diversion of these medications. I always show this slide. This is your brain on drugs slide. Okay, this is a PET scan showing someone who has opioid dependence. In the opioid-dependent brain, you can see there's a lack of red in the opiate-dependent brain, and that shows a reduction in brain function. The main idea is that someone who has been addicted to opiates has a different brain than someone who's not been addicted to opiates. Now, you could ask the scientists, did they have that when they went in, or did the opiates cause that? And you don't get a great answer to that. The bottom line is, though, that the brain physiology is different in someone who's been addicted to opiates. How do we define addiction? This is really important. Addiction is a substance use disorder where the person has a problematic pattern of using alcohol or another substance that results in impairment or daily life or noticeable distress. We used to say for alcoholism, well, anyone who drinks more than the doctor has an alcohol problem. You can't use that for obvious reasons. But the main idea with addiction and the use of a harmful substance is that it's impairing your life in some way, whether it's your work, your education, your relationships, your physical health. It's hurting you. And this is, and I'm not asking to read all this, but I just want to point out that this is a NIH protocol put out for treating addicted people. And the important piece is, and I've underlined them for myself at least, that these are the DSM criteria. It shows worried about cutting down or stopping. The person spends a lot of time doing that. They drop important obligations for the use of the drug, like a job or a marriage, those kinds of important things. Tolerance and withdrawal are at the bottom, okay? So just having tolerance to a drug or withdrawal from the drug does not mean that you're addicted. It just means that you're physically dependent. And that's going to be an important distinction that we're going to talk about today. What is dependence? Building up tolerance means that you need more of the drug to get the same effect. I see people writing. I'm happy to send these slides when we're done. So you need more of the drug to get the same effect, or you get less of effect from the same amount of the drug. Withdrawal is the obvious effects that you get from stopping the drug. Neither of those things means that you have addiction. They're physical effects of a particular substance, and plenty of other medications cause them. So I want to talk about the goal of addiction treatment. And I think it's important when we're thinking in any addicted person, what we're looking for. Are we trying to get them to stop all addictive substances? Are we trying to get them to stop the one that may kill them in the next 6 weeks? Are we just trying to reduce harm to them? Are we looking for improvement in their psychosocial variables? Are we looking for their life to get better if they reduce their use of a substance? And this is one I'm not giving you the answer to. I mean, I think that's a question that we need to address as clinicians and as drug court providers, what we are looking for. I'd be happy to talk about that more at the end. Related to that is how we measure the efficacy of addiction treatment. As Garrett eloquently told us, he didn't start treatment and then stop drugs immediately, right? He had several slips and relapses. Does that mean treatment failed? Obviously not, actually. Are we looking for abstinence at a year, at 6 months? What are we looking for? Are we looking for improvement in physical health and mental health? We have to define what we're looking for measuring the efficacy of addiction treatment. And this is what we always run into in doing studies on the effects of medications. People ask, well, does it work or doesn't it work? And it depends how you define what works or not. We're looking at 6 months or 12 months. What are you defining working as? And we'll talk about that a little more. Now, I'm going to be talking today about medications, but I never want to minimize the efficacy of psychosocial treatments for addiction. As an addiction psychiatrist, I never only prescribe medications, and it's part of the treatment modality I'm going to tell you about that we must give other kinds of treatment along with medications. Medications are always symptom relief, they're not full treatment. So, in addition to the 12-step groups, which we'll talk about in a second, motivational interviewing is a highly effective manualized treatment for addiction. Cognitive behavioral therapy, similarly highly effective for the treatment of addiction. Family therapy can be useful for treating addiction. Contingency management strategies where someone is paid for sober time, highly effective also. There are a number of other effective and growing approaches to the treatment of addiction that have nothing to do with medication. Not my subject today, but I don't want to give you the idea that medications are the only way to go. They're certainly not. Narcotics Anonymous, Garrett mentioned peer support groups. And as an addiction psychiatrist, I am very much allied with AA and with NA. I think they're wonderful. I've seen some patients' lives saved by these groups. The fact is that not everyone sticks in AA, though, right? And AA is not a treatment of itself, nor does it claim to be treatment. It's a peer support group. I send everyone who comes into my practice to AA and NA, but it's not a professional treatment, and it doesn't meet the same criteria that my treatment or any other clinician's treatment meets. It's an extremely useful adjunct to treatment. So when we're talking about medications, and this is my subject for today, what do we look for? Where do you want to treat someone who's got an addiction problem with medications? And I'll talk about the obvious first and then get down to the nitty-gritty of where I think the issues arise. First of all, in intoxication and overdose. If someone's got alcohol withdrawal, it's an absolute obligation to treat them and to make sure that they don't have DTs and die from their disease. If someone's got withdrawal from an opiate, it's going to be usually not dangerous, but extremely uncomfortable, and I would consider it cruel and unusual not to treat them. But treating someone who needs to be detoxified is the easy part. It's not the full treatment. Any physician can treat someone to make sure they don't get sick or die from withdrawal. Abstinence initiation, use reduction. When you're getting someone into early abstinence, there are a number of medications which I'll talk about which help you do that. There are medications which decrease craving for alcohol. There are the opioid medications I'm going to talk about which will help cut the withdrawal so someone will be able to start treatment. If you can't sleep and if you're having sweats and you're dripping from your eyes and your nose, you certainly can't sit in a group and work on your addiction. So the medications we have will treat that. Now, relapse prevention. This is where we get into the issue, where the issues usually arise with medications. What about keeping someone on a medication for a long period of time? Is there an indication for that? And I'm going to suggest that there is, and I'll tell you about them in a second. But this is relapse prevention, where someone stays on a medication for 6 months or a year or 2 years. And I never want to forget dual diagnosis. People who use drugs and alcohol often have co-occurring psychiatric illnesses, which sometimes need to be treated separately with different medications. And there's no question that if you fail to treat someone's psychiatric illness along with their addiction, you will fail that patient. So tapering versus maintenance, that's what I just talked about. When someone comes in opioid withdrawal, for instance, they can be given a 10-day course of methadone, a 10-day course of Suboxone to taper off their opioid use and get back to not using anything. Maintenance is for those situations where someone needs to stay on the medication over the long term. And really the only controversy I know about is over maintenance. So I talked really about some medications that are used. There are medications for opiates, there are medications for alcohol, there's one medication for marijuana withdrawal, there's no medication that's been found by the FDA to be effective for treating cocaine use, and there are medications that are used for treating tobacco, for nicotine withdrawal. Although it's not my subject today, tobacco kills more Americans every year than cocaine, alcohol, and heroin put together. So there are medications that are extremely helpful for treating someone's nicotine withdrawal. I wouldn't be doing my job if I didn't tell you that. So when does a doctor consider someone for medication for their substance use disorder? They look at the severity of the concomitant medical illness. Is someone suffering from hepatitis C? Is someone suffering from HIV? Is it absolutely necessary to get their addiction treated right now? Is there a pregnancy involved? Does that necessitate immediate treatment? Where are they in their recovery? That again looks at whether intoxication, whether they need to initiate treatment, or whether they need to be maintained. The bottom line is that it's often a choice to recommend a medication for the treatment of opioid use disorder. It has to be based on the severity of the situation. It's often based on how many times a person has tried to get sober without the medication. And I'll talk about that in a second. So, basic medication strategies for substance use disorders. One is an agonist. An agonist means it hits the same receptor in the brain. So, I use the example of the mu opioid receptor. That's what we're going to be talking about mostly today. We all have opioid receptors in our brain. If you take morphine in the hospital, if you're in an accident, it'll hit that receptor. If you took heroin because you're addicted to it, it would hit that receptor. If you take buprenorphine, which I'm going to talk about today, it'll hit that receptor and block it. So you will get an effect from it. If you take an antagonist, which is just a blocker, what that does, it covers the whole receptor. So you all know about Narcan naloxone, right? Does everyone know about that? Police officers carry it, EMTs carry it. It reverses an opioid intoxication state. So if someone has taken morphine or heroin, naloxone comes, knocks it off the receptor, and renders the person able to breathe, and usually try to punch the EMT in the face because they're in immediate withdrawal. Another problem. But that's what a blocker is. It blocks the receptor. So Narcan naloxone is a short-acting one that EMTs carry. The long-acting one is called naltrexone. That blocks the receptor also. So if you block that receptor and you take heroin after that, what will happen is nothing. Okay, and that's why it's so effective in those patients who will take it. There are aversive medications. If everyone knows about antabuse disulfiram for alcohol, what happens if you take antabuse and then you drink, you're going to get very sick. You're going to get a headache, you're going to get a flush, you're going to get sweats. And the idea is to be aversive to prevent someone from using it in the first place. Not used as much as the others, but it is used. And again, treatment of underlying psychiatric disorders is enormously important. So again, I told you about the medications that are approved by the FDA. I told you about there's some opioid medications which we'll talk about, alcohol medications, benzodiazepine, there's one that's used for withdrawal, not much for treatment, and the tobacco medications. Now there are medications that are used for the treatment of cocaine, methamphetamine, hallucinogen dependence, but they're not FDA approved. But as you probably know, the fact that something is not FDA approved does not mean that physicians may not use it. It just means that they have to say that it's not FDA approved. And some of these medications may be FDA approved down the line, but they're not now. I tend to stick to ones that are approved by the FDA for obvious reasons. So what are the medications usually used for opiate dependence? And this is what I want to focus on today. Methadone, which we all know about, hits that mu opioid receptor I told you about. It activates it, and it will prevent the person from going into withdrawal. After 3 to 5 days at the right dosage, the person will feel nothing. They won't feel high. They won't feel like they're sedated. They will, as long as they don't use anything else, they will feel normal. Buprenorphine, as I told you, both hits the receptor and blocks it, and it has some other good effects that make it different, if not better, than methadone. Naltrexone is the blocker I told you about, and it's a totally different animal from the top two. So, as I said, agonist therapy is a long-acting medication in the same class as the abused drug. It prevents withdrawal. It induces tolerance, and this is what I said earlier, that someone who takes Suboxone, as we've already heard today, if they stop, they're going to withdraw. right? In the same way that if you and I go to the hospital with a hip fracture and you're given morphine, when you go home, you're going to withdraw from the morphine. No one says you're an addict, but you're going to withdraw from the morphine. What agonist therapy is not is substituting one addiction for another. And for the reason I said, someone who's on a stable, effective course of Suboxone, their life is going right. They're able to work, they're able to go to school, they're able to have relationships, and their physical health is fine. They're not addicted. So who's appropriate for methadone therapy? Let's talk about methadone first. The rules say, first of all, methadone must be prescribed in a federally sanctioned clinic or a hospital. As a private practice clinician, I'm not allowed to prescribe it. They have to be older than 18 years old. They have to have had greater than 1 year of opioid dependence. This is a rule often broken, but the idea is that you don't just prescribe methadone immediately to someone who tried heroin once. Sometimes people who are medically compromised are prescribed methadone. Infectious disease, as I said earlier, sometimes in order to get the addiction and the medical illness under control, they're started on methadone. How do you diagnose an opiate use disorder? Even think about using one of these medications. What does our diagnostic manual tell us? You have to have a complete history from the individual, what they've done over the years, how they tried to stop. You look for signs of dependence. One of them, withdrawal. Other physical ones, tracks on their arms. Are they doing something harmful to themselves? Doing urine toxes to make sure that the person is actually using the substance that they said they're using, and to make sure that they're not taking something that they didn't tell you about or that they actually didn't know about, which is common enough for teenagers. For methadone, you have to do a cardiogram. If you're worried, you can do a naloxone challenge, which is put a little bit of that Narcan under the skin to see if the person withdraws from it to prove that they're taking an opiate. And there are some manualized workbooks for measuring opioid withdrawal, which you could do. If you're doing a research study, you would do that. I guess if you want to prove something, you would do it. But most clinicians can tell opiate withdrawal at about 100 yards. So you don't necessarily need to make the scale. So first of all, with methadone, you can certainly taper someone and detox someone with methadone. And I ran the detox at Bellevue. We often would do that. Someone would come in order to make them more comfortable. We'd taper them off, detox them with methadone. But for maintenance therapy, someone who needs to take this medication over a long period of time, it's a long-acting mu agonist. It lasts for about 24 to 36 hours. It's common enough when someone is well treated with methadone that they will forget their medication one day and be halfway through their workday before they remember because they start withdrawing. The dose is enormously important. If you give too low of a dose of methadone, they'll be able to use heroin on top of it, and they probably will. If you give too high of a dosage, you will sedate the person. If you really give too high of a dosage, you could cause an overdose. So 30, the usual blocking dose is between 60 and 80 milligrams. And when we say blocking dose, that blocks craving for opiates. 30 to 40 milligrams will stop withdrawal, but usually people describe craving at that level. The range runs from, some people for whatever reason take 10 milligrams. Other people need more than the federal limit of 100, and you simply get a waiver for that. I'm going to have questions at the end if you don't mind. I'm sorry. I just want to get through this, and there'll probably be a lot of questions, but I'll come to you first, okay, man? So maintenance therapy with methadone, and I'm going to talk about the benefits and the risks of each of these medications. The reason is that anybody who tells you about a medication, they don't tell you about the good parts and the negative parts of it. They're not telling you the whole story. So I want to make sure that we have this discussion about both methadone and buprenorphine. The benefits of someone who is well treated with methadone are lifestyle stabilization. Obviously, the person is able to get their life together. They don't spend their life chasing drugs. I mean, I've had many addicted people say to me that, my getting drugs was a full-time job. There's no question of my going to school or working. I had to spend my life doing it. It improves health and nutritional status, and these are studies across the board. It decreases criminal behavior. No one's looking for money for drugs. Increases employment. There's obviously a decrease in injection drug use and shared needles and HIV. What are downsides of methadone? Overdose is possible with methadone. God forbid a child takes a dosage of methadone they find in mom or dad's refrigerator. Oversedation is possible. This usually happens in the context of someone who's taking other drugs, and one of our downfalls in the field are the methadone clinics, some of which have a lot of people selling drugs around them. And if you use methadone in addition to Xanax or Valium or something like that, you're putting yourself in a world of trouble. Withdrawal happens, there can be EKG changes, and that's why you do an EKG at the beginning. Diversion is obviously a problem. You can get high on methadone if you're not already tolerant to it. And I think there's the meaning of maintenance treatment. What does it say to a young person that I think you should be on this medication for a year or 10 years? And what does that do to that person psychologically? And I think that's something that I always consider if I'm recommending one of these medications. What is the Drug Abuse Treatment Act of 2000? That's allowed doctors to prescribe buprenorphine in the office. The drug problem, which has come to a head over the last 4 or 5 years, had started long before this. There was an obvious concern that people who needed treatment with opioid medications were not being treated. Buprenorphine was brought on board, and private practice clinicians like me were allowed to prescribe to a small number of patients. And you have to do a training course. You have to prove that you're knowledgeable about the medication. Let me talk about buprenorphine, Suboxone. And understand, Suboxone is buprenorphine combined with naloxone. The reason is that it's to prevent diversion where someone will either crunch it up and snort it or crunch it up and shoot it into their veins. It's got naloxone in it. So if you do that, the theory is at least that you'll have immediate withdrawal because your body will react to the naloxone. If you take it orally the way you're supposed to take it, the acids in your mouth and your GI tract will break down the naloxone because there's not that much of it there, and you won't get the withdrawal reaction. So that's what Suboxone is. Subutex is buprenorphine alone. It's got no naloxone in it. It will not prevent it from being injected. The reason it exists, at least according to the initial studies, is because it wasn't clear that pregnant or nursing women should be taking naloxone at all. So this was for that population. I will tell you that there's a certain number of people who can't tolerate Suboxone and must take Subutex who aren't pregnant or male. So that being said, what are the characteristics of Suboxone? It's a partial long-acting mu agonist. The duration of action is similarly about 24 to 36 hours. The dose ranges, well, it says 8 to 32. Actually, some people take 2 or 4 milligrams and are held at that level. And 32 is usually the highest that people go. There are new formulations you probably know about. There are sublingual tablets. There are also strips that you can put on your tongue like a breath strip. What are the benefits of Suboxone? Compared to methadone, one benefit is you don't have to go to a methadone clinic. Another benefit is, and I'll show you this in a second, that there's a ceiling effect, that you are much less likely to overdose from Suboxone than you are from methadone. The reality of that is that combined with other drugs, Suboxone can certainly cause a fatal overdose. It's extremely unlikely to do so on its own. And also, people don't get high if they take double the 32 maximum. If they take 64, they will not get any more effect from it. Anyway, the benefits. Lifestyle stabilization, same thing as methadone, can be provided outside of a methadone clinic. It's available by prescription. Withdrawal is more easily tolerated than heroin or than methadone. I will tell you, people who are addicted to drugs will say that when they withdraw from Suboxone, it's not as severe as methadone or heroin. It just lasts longer. So it's kind of choose your poison. I mean, if you can't sleep at 10 days, that's pretty bad, even if you're not having a terrible withdrawal. There can be one physician for patients with multiple illnesses. What I told you before about methadone means that a general doctor is not allowed to prescribe it. And so a doctor treating a patient for HIV or for hepatitis C can't prescribe methadone. He or she can prescribe buprenorphine and can sequester all that person's treatment in the same place. What are the downsides of buprenorphine? Diversion. Garrett talked to us about that. He bought Suboxone on the street. And I don't know the details of it, but people do that. It's a concern, and I think that it's a concern that's been in the media over the last 6 months or so, and maybe we'll address that in the questions. I will say that the majority of people who buy Suboxone on the street are trying to get themselves treated. They'd be better off treated in a doctor's office or in a clinic. Usually they're trying to get themselves treated. When I ask addicted people, why'd you buy the Suboxone? They say, well, either I couldn't get heroin, or they say that I was trying to do what you're doing, doc. I just didn't want to come into the office. And so I don't want to whitewash Suboxone, but I'll tell you the majority of people that buy it on the street are trying to treat themselves. The other thing that they're often trying to do, and this is not a pleasant thing to say, they're sometimes trying to use less heroin, okay, or less pills, or fewer pills. Sometimes because they can't afford it, sometimes because they're generally trying to cut down the amount of illicit opioid that they're using. And we could talk about whether that's a good thing or a bad thing, whether that's harm reduction, whether that should be at all acceptable. But that's often what people say. There's withdrawal from buprenorphine, Suboxone, I told you. And again, the meaning of maintenance treatment. When you say to an addicted person, you're going to need to be on this for 2 years or 5 years or 10 years, what does that mean? For some people, it means that I'm going to be a slave to this medication the rest of my life. I don't want it. And in a way, I agree with that attitude because I think it's a healthy attitude. Be very careful what substances you put into your body. On the other hand, having experienced up close and personal opioid overdose deaths of young people, I don't want someone to take that philosophical attitude and put themselves in mortal danger. So I think it's something one has to talk about with the patient on a case-by-case basis. Oftentimes the meaning is that at the beginning, then someone starts taking a medication like Suboxone and they say, well, you know, I got my family back, I have a paying job, I feel fine, I forget I take the medication, I don't have any desire to stop this medication. In the same way that someone who takes medication which treats their diabetes or treats their hypertension would not have anyone in their family say, why don't you just tough it out, man, you don't need that insulin. I wanted to show you a document, and I'm going to show you a couple today. This is a SAMHSA document that is available on the internet, and it's called Medication-Assisted Treatment of Opioid Use Disorder. And if you're interested in this, I would go ahead and take a look on the internet or order a couple of brochures for yourself. He gives a very sort of non-biased description of what maintenance medication treatment can do and what it can't do. The reason that the federal government is putting these things out right now is because our opioid use epidemic is starting to morph. You know, over the last, I would say, 4 years, the DEA has been rightly tightening up the flow of prescription pills. So people are less likely to be able to get prescription pills. I've had many people in my practice say I couldn't get the oxycodone. It's a lot easier and cheaper to get heroin. So that's what often teenagers move to. Extremely worrisome. This is another document which you don't need, but it says prescribing opioids for chronic pain. I think it's sent to every physician in the United States. I've gotten like 3 of them in the mail in the last 2 weeks. It's trying to cut down on the number of physicians who are thoughtlessly prescribing opioid medication. And I think that, you know, I'm involved in forensic psychiatry, so I see malpractice matters. Sometimes, you know, if there's a pill mill and a doctor just prescribing medications, that's just a criminal act, and it's got nothing to do with regular medicine. What does happen on a fairly regular basis is that simply giving patients opioid medications without having a clear assessment of what the patient needs and what the patient wants, and it's easier just to write the prescription and get the person out of your office. So these efforts are meant to cut down both on thoughtless prescribing as well as making treatment available for people who need it. This is a study, and again, if you contact me, I will send you a boatload of studies, but this is a primary case, Suboxone taper versus maintenance, prescription opioid dependence study. It was a 14-week randomized trial. They found tapering less efficacious than ongoing maintenance treatment in patients with prescription opioid dependence. So they found tapering detox less effective than maintenance. And the indices they used were employment, physical health, relationships, mental status. So, and this study is just indicative of a number of other studies that are out there that show that in some populations, maintenance is much more effective on those markers than is simply tapering a detox. So I want to not avoid naltrexone, which is Vivitrol, I think, in the trade name. That's the medication I told you about that blocks the opioid receptor. And it seems like it would be the perfect treatment, right? If someone would just take this medication and their opioid receptor is blocked, they could never get high. I mean, and usually doctors or nurses who are prescribed this medication say, well, what if I get in a motor vehicle accident and I break my femur, then they won't be able to give me morphine. True, that is true. There's a way to overcome the opiate blockade. I've never had that happen in my practice, nor have I ever heard of it happening, but I trust every healthcare clinician thinks of that possibility. Again, it blocks the effect of a opioid medication that you take. You have to be free from opioids for a long period of time before you take it. Otherwise, you'll go into protracted, extremely uncomfortable withdrawal if you take it. The issue with Vivitrol and naltrexone, and I do prescribe it in my practice in certain cases, is that there's a pill that you can take every day. Obviously, like all medications, you must take it in order for it to work. There's also an injection called Vivitrol, which you take once a month. and that it stays in your body for probably 28 days, which is extremely effective in blocking opiate use. People generally don't respond as well to it as they respond to Suboxone. Some do, some don't. The population that I use it for are people who either don't want Suboxone or who are for some reason can't take Suboxone. I also use it sometimes in older teenagers who I don't think it's appropriate to prescribe Suboxone, and we want to have some way to, frankly, prevent them from overdosing before they get out of high school. So you have to be free for 7 to 10 days. There's some argument maybe you can get it in a little earlier. He doesn't have severe active liver disease, not allergic to naltrexone, obviously. So naltrexone, Vivitrol is something maybe we'll talk about a little later. Again, outside of drug courts, people don't like it as much, and there's much more choice outside of drug courts. We might talk about the issue of you mandating naltrexone, Vivitrol, whether that's a useful protocol. Again, I'm a doctor, not a lawyer, so I can't really speak to any legal issues there. But I will say that the rates of relapse as soon as someone stops the naltrexone are extremely high. So once you pull that blockade off, someone's extremely likely to return to opiate use. Frankly, they are also for buprenorphine and methadone, not as highly, but they're likely to relapse. So why is there a reluctance to prescribe medications for addiction? First of all, there's a lack of available prescribing providers. I will tell you that the Suboxone, people who can prescribe Suboxone have to take that special course, and they can only, up till about 6 months ago, can only prescribe to 30 patients or 100 if they got a waiver after 2 years. Now the number is up to 200, but there aren't enough of us out there. And reality is someone who does education for clinicians who can treat Suboxone, a lot of people we educate never do it. And the reason usually is they feel they don't have any support for their prescribing procedures. The pharmacology of Suboxone is easy. I just described it to you in about 5 minutes. It's the addicts who are hard, right? Who also have psychiatric illness, who are going to lie and cheat and steal from clinics. And there has to be a thoughtful way of managing that and treating that as a problem rather than a moral problem. There's a concern amongst clinicians about over-reliance on medication. Are we simply doing what I said we're not doing, giving one addiction, substituting one addiction for another? Concerns about enabling. Are we just giving someone the drug that they want and letting them walk through the rest of their life high? And concerns about medication safety and related issues, right? Methadone can be viciously dangerous. I don't deny that Suboxone can be dangerous to someone who's not taken it in the past. These are the principles of effective treatment, and this is by the NIH. And again, I'm not asking you to read all this stuff. I would just tell you that the National Institute of Health says very clearly a couple of things that are relevant to what we're talking about today. They say medications are an important element of treatment for many patients. So the NIH says clearly medications can be important. They're not saying for all patients, but they're saying for some patients. Further down the list, they say treatment does not need to be voluntary to be effective. Now, for drug courts, I'm sure you're well aware of that. As Garrett explained to us, it certainly was extremely helpful for him to have non-voluntary treatment. But long before drug courts were popular, it was clear in the psychiatric literature that addiction treatment works about as well if someone's mandated to it as if they're not mandated to it. So however you get into the room, it can be helpful to you. And that speaks to my friend Sheila Bloom's thoughts on the spectrum of treatment addiction voluntariness. She said, and this is actually in the early 90s, I believe, that we shouldn't talk about mandated drug treatment. We should talk about varying levels of addiction treatment voluntariness. It's the same thing, but it's a nicer way of saying it. And she said, and I agree, that everyone who goes to addiction treatment is mandated. Sometimes you're mandated because your spouse says, I am not going to parties with you anymore because you get drunk and it's annoying and it's irritating and it's embarrassing to me. And that's often enough of a mandate for someone. Other people are mandated by the welfare office, which says, after 2 years, if you're using or if you're not getting treatment, you can't get your welfare payments. Other people are mandated because a judge says either you go to DUI school for the weekend or you go to jail for the weekend. Most people choose DUI school. There's parole and aspects where someone can be earlier paroled if they get treatment. There are facilities where someone can get treatment inside of a jail or a prison and decrease their sentence. In some jurisdictions, not where I work, someone can be mandated into treatment by a judge for up to 6 months, actually. So the idea is that everyone's mandated to addiction treatment. In your courtrooms, they're mandated by you, and it's a legal mandate. But oftentimes mandates come long before a judge says anything. And so the idea that Sheila brought out is that we should be comfortable with that as clinicians, that the fact that someone's forced to do something doesn't mean that it's a bad thing for them. It doesn't mean that they're not going to accept it. I work in sports and test athletes for performance-enhancing drugs, and oftentimes they're tied up with drugs of abuse, and mandating someone or sanctioning someone is something that I've seen often save lives. And sometimes people say thank you for having done that. Other times they never say thank you. But in any case, you can know you're doing the right thing clinically. So this is something I talk to doctors a lot about, how to safely prescribe addictive medications. It's important for us to hear because I think one of the concerns in drug courts is diversion of appropriately prescribed medications. Again, I'm not talking about pill mills where someone's a criminal and selling prescriptions. I'm talking about how a physician carefully prescribes these medications. And this is what we want to avoid. This is a case I read about in the newspaper where a Oklahoma physician was arrested for 9 counts of homicide and 43 drug counts. His prescription patterns had been so obviously thoughtless that he was accused of and actually convicted of murder and is in prison right now. And I show this to doctors to say, obviously, this is one place you don't want to be. What are the red flags for misuse or diversion? Obviously, the symptoms of intoxication or withdrawal. If someone's agitated, if your teenager is coming home 4 or 5 nights a week and falling asleep in his mashed potatoes, he's not tired. He's high. And it gets kind of a giggle, but I have seen that enough times, and there's enough denial on the part of we parents that you have to open people's eyes and say, if you see something, if you're worried about, like the signs say in the airports, if you see something, say something. If there's demand for a particular, usually fast-acting, if it's a stimulant medication, I need Xanax. I can't take Valium. I need the short-acting stimulant. I can't take the long-acting one. I need Suboxone. I can't take that Vivitrol. And the reason I put that up there is to differentiate between circumstances where someone's looking for a particular drug of abuse to get high, and there are other circumstances where a medication works for a particular person. They really want that medication. I treat some patients in my practice who, at day 28 of a 30-day prescription, call me and say, did you call in the prescription yet? And it's not because they're trying to get high, it's they're trying to prevent me from being forgetful, because they need that medication. So I often tell people that the fact that someone is medication demanding doesn't necessarily mean that they're using it to get high. It may mean that it's extremely effective. They don't want to lose that effect. Repeated lost prescriptions, notwithstanding no one's ever lost a prescription for penicillin. In my practice and a lot of practices, people will say there's a one lost prescription rule, because I understand things happen sometimes. But, and again, having been involved in malpractice cases, as long as there's a clear office policy that the staff and the physician adhere to, that's going to be understandable, whether it's one lost prescription or 2 lost prescriptions over a lifetime. But when people start losing prescriptions, you want to get very aware of that. Luckily, in every state except Missouri, there's a pharmacy management program now where any prescriber can look up and see what the person has gotten in that state as far as controlled substances. So if I'm going to prescribe someone Suboxone, I'd look them up on the monitor and I can see what they've gotten in New York, New Jersey, Connecticut, Delaware, and a couple of other states. So, and I've gotten some unpleasant surprises. The bottom line is that lost prescriptions and obviously multiple prescribers, which you might find on that site, is a big marker for an addiction problem. So prescribing medications with the potential for addiction, and I include Suboxone in that category. I think if you're going to prescribe it, you have to acknowledge that the potential for misuse or diversion is there. And I've tried to give you a full picture of what Suboxone does and what it does not do. And I think that as prescribers and perhaps as drug courts, we need to be aware that there's no way to prescribe this medication and be 100% that you're not causing problems with it. I would say the same thing for chemotherapy, right? I mean, it's dangerous, but there's sometimes a very good reason to prescribe it. There has to be a risk assessment done of that particular individual for misuse or diversion. You have to look at them at each visit. I tell clinicians to ask questions matter-of-factly, to not be insulting or provocative with patients. Be aware of countertransference. That's a fancy word for the doctor's reaction to a patient, right? If I see someone who's homeless on the street and obviously intoxicated, my suspicion for drug abuse is going to be up here. If I see someone in a suit and tie, my suspicion for addiction might be a lot lower. It shouldn't be. And I've learned that lesson many, many times. In the context of drug courts, where can you get clinicians who are knowledgeable about opioid medications, about these medication-assisted treatment? There are ways to get treated. I have them listed up here. The American Academy of Addiction Psychiatry, the American Osteopathic Academy of Addiction Medicine, the American Psychiatric Association. There are all kinds of places where clinicians can get trained. It doesn't have to be doctors. I think that if you are getting advice from a clinician in your courtroom, you should listen very carefully what that person tells you about where the science is as far as medication-assisted treatment. This is a brochure called Educating Drug Courts on Medication-Assisted Treatment. It's put out by NDCI. If you look this up online, I think there may be some on a table out here, you will find information directly relevant to your drug court. You will find information how your clinicians can get trained on these medications. We'll answer some basic questions about these medications. So what are my take-home points before we get to questions and discussion today? First of all, addiction is a biological disease. Like any other biological disease, it's got some choice attached to it. There are 3 medications which are FDA approved for treating opioid addiction. They're naltrexone, methadone, and buprenorphine. These medications are appropriate adjuncts and should be considered part of the toolbox. If I say nothing else to you, I would say that these medications should be part of your toolbox. They're not right for every patient. They're right for some patients, and that may change over time. Someone who may have not been appropriate for it, now 6 months later may be very appropriate for it. These are some references you could look at. And again, I'll send my slides to anyone who wants them. And it shows some studies on the neurobiology of opioid dependence, where it comes from. It talks a little bit about naltrexone at the bottom. And I don't want to talk about my cases. I prefer to talk about questions and discussion. I'm quite sure I said some things today which people didn't agree with, and I'm happy to address those. But there's a lady over here who had a question, please. If people didn't hear, the concern was that methadone clinics, in your experience, are places where where people are getting their methadone and then selling it elsewhere. They seem like they're kept on the methadone forever. And then the question at the end was whether someone can be transferred over to Suboxone. Thank you for the hardest question first. Don't hold off, yeah. First of all, a methadone clinic that's keeping everyone on medications permanently is not doing their job the right way. I think that some methadone patients should be kept on methadone permanently because they need it. Other patients should be tapered off over a short period of time. Now, the problem of someone taking methadone that they get in a clinic and either spitting it out when they leave or just getting a take-home thing and selling it, again, the methadone clinic is failing their patients, and I understand that addicted people can be quite manipulative, but the protocols are not in place at that clinic for making sure exactly that does not happen. Frankly, with that level of problem in the clinics that you're telling me about, I'm not sure that buprenorphine is any better, right? I mean, if that clinic just prescribes buprenorphine, my worry is that the same issues would obtain with buprenorphine if they're the same individuals and the same protocols. And that's what you said is what I was trying to get at with one of the problems with methadone clinics. Some of them, not all of them for certain, but some of them have gotten to be exactly where you're describing, where they're simply kind of going through the motions and prescribing someone their daily dose, and we have some percentage of people who are going out and selling it. So, unfortunately, I don't have a good solution for that. But I don't think it's simply changing someone to buprenorphine. The problem is with the clinic itself. It's not with the medication they're prescribing. Please. Yeah, if you didn't hear in the back, the question was how quickly the methadone clinic should be increasing the methadone dosage. They should be increasing it rapidly in the first week up to the blocking dosage. Now, I'm not sure if you're implying that by physical effect you mean they seem sedated to you. Yeah, that should not be. In the first week to 10 days, someone should be increased to a level where they're not intoxicated or sedated, but also they're not having craving. The reason being that beginning of treatment is a really difficult place to be, and that's where overdoses often happen. So they should be going up quickly, but they shouldn't be going to a place where someone's sedated. If someone appears sedated to a person on the street or to a clinician, it's evidence that they're getting too much methadone, or something bad is happening. Maybe they're getting something on top of it, but I would agree with that. Other... I'm sorry, I can't see very well.
There's one over here.
You guys don't seem like a very shy audience, so. We're bringing a microphone around here. Yeah, please. I'll repeat it if you want. Yeah. Well, thank you. The question, if you didn't hear it, that that all I said, well, if it's used the right way, X, Y, and Z will happen. And the questioner has said, well, it's not used the right way. I mean, addicted people don't use medications the right way. I have a friend who's in recovery who says that if there was a pill that cured alcohol addiction, addicts would take too much of it.
Okay.
But I think your point is well taken, and I probably should have brought that out, that you can't rely on someone with an addiction problem to use the medication in the correct way. That's why things like a pill count, things like urine drug screens to make sure some of it's getting into their body need to be done. That's why close treatment that's got almost nothing to do with medication needs to be in place. A clinician needs to be seeing that person on a regular basis. And I hope that's not pie in the sky for the kind of clinical treatment that you're seeing. But I will tell you that is the way to get people to take their medication correctly, especially addicted people. And I will also say that, to your point, I don't think that's ever going to be perfect, even for someone who's trying to take their medication the right way, but especially for addicted people. So we're never going to get 100%. But in order to get someone to take these kinds of medications the right way, they have to have very clear oversight by a clinician who's helping them do that. But I agree with you, it's a huge problem, and it's going to be a problem with addicted people. No way to avoid that. Please. So you're asking that since you don't have a connection with a psychiatrist who's able to prescribe these medications, you really have no place to go with it, right? Yeah. That's a huge problem, and that's what I was trying to point out, that as a field, we've failed to train enough people to use these medications, and so you can't even get to the point where you're helping some patients and not helping others. You're not helping anyone who's got an opioid use disorder. Other than our continuing efforts to try to get clinicians out there who are competent to make an assessment and decide if the person needs maintenance treatment, unfortunately, I can't offer you anything more than that, but I understand, and waiting 4 to 5 weeks for someone who's got an opioid use disorder who may need this medication is far too long. I'm sure you're in agreement. But other than trying to train more people, I don't have a great answer for that. There's another question over here? Please.
One of my concerns about medically assisted treatment is the transparency between the prescribing physician and our team. So my question is, basically with protected health information, have you ever worked with the drug court team? And then has there been increased provisions beyond a regular release of information that has allowed you to be more effective?
Thank you for bringing that up. The point is, the concern raised is there's a lack of communication, if I understand you, between the treatment team and the drug court. Right, it's a huge problem. And it's based on a misunderstanding of medical record law by clinicians, right? Because we are, especially as there's a higher burden for drug and alcohol clinicians to keep medical information private, right? And the idea was good in order to try to prevent stigma attached to addiction and not get people in trouble because they're getting treated. Unfortunately, a lot of clinicians have taken that as we can't tell anyone if there's a drug or alcohol problem. In these circumstances where someone is prescribed a medication under the auspices of a drug court, the patient has and must give up that confidentiality right. So there has to be communication. So the patient has allowed the clinician to talk to the drug court. Otherwise, you don't have any communication at all. So we clinicians have to understand that once the patient has allowed us to pass that information, not only should we, but we must pass on the information to the court. So that I think is a deficit on the part of clinicians. And I think that's changing. I think that the law is changing that also. I mean, an unintended consequence of 42 CFR and HIPAA has been to sequester drug and alcohol records away from the rest of the medical record. So some doctor who's seen someone in an emergency room, even like a drug court, doesn't know that the person's had a treatment for opiate use, or doesn't know that the person's had alcohol withdrawal 6 months ago. So that problem is being fixed on a federal level because we're bringing down those barriers to passing information about drug or alcohol use. In a drug court scenario, I think the court can make it crystal clear that once the patient has given the okay to pass medical records on, the clinician not only is allowed to, but must do it. The patient's asking you to do it. The records belong to the patient. The information belongs to the patient. So once he or she says, I can pass it on, you can pass it on. So that's on our side. That's on the clinician's side if we're not passing on information. And I think clinicians may need to be educated about that. National groups like the American Academy of Addiction Psychiatry, the American Society of Addiction Medicine are working on educational efforts to do exactly that. But that's a huge problem for drug courts. Yeah. Other questions and points? Sir. Oh, that's a good question. Can a patient on Suboxone maintenance develop tolerance to it? The short answer is yes, but it's very unlikely. Right? Once they're at a therapeutic dosage, which I said should be up to 16 milligrams, up to 32, they're unlikely to develop more tolerance to it. I've had patients on these medications for 10 years and they're fine. They don't have any tolerance to it. but it can happen. It's vanishingly small, but again, it's another one of those things. If I say it never happens, that's not true exactly. It can happen, but it's unlikely. Unlikely with methadone too, actually. Please. Sir. That's a good question. How much? I'll speak to methadone. Methadone is very inexpensive because it's off patent. I actually don't know what the cost is. Suboxone, up to the time it came off patent a few years ago, was enormously expensive. So if Medicaid or your insurance company wasn't paying for it, it would be essentially unaffordable for most people. Luckily, Suboxone came off patent a few years ago. So now there are several other preparations called Subzolve is another one, and there are generic strips available. So it's much less expensive. I would say, though, that unless it's paid for by insurance or paid for by Medicaid, it's unlikely someone's going to pay out of pocket for it. It's in the order of hundreds of dollars a month. I think, a patient of mine, for whatever reason, doesn't have insurance, is paying $350 or $400 for, I think, a 16 milligram. Pardon me?
How much is dollars?
$350, I would suggest, for a month. That's what I've been told in my practice. I think it may be different in different states. But again, if you have private insurance, it should pay for it. Medicaid pays for it. And in federally sanctioned clinics, I don't think people are charged for the methadone. Yes? The longest. The question was, what's the longest I'm aware of a physician having prescribed Suboxone? I know there are some patients who take it indefinitely, right? I mean, it came out in the late 80s for ongoing maintenance use. Some people have been maintained since then. There are people in the media who take it, I know for a fact, and who look fine, look like they have fine careers. So, yeah, you can take it indefinitely. I'm not suggesting that's right for everybody, even most people, but you can take it indefinitely. Other questions or points? I'm sorry, I can't. Yes, please. Yes. Yeah, that's a good question. What's available for methamphetamine addiction? No medication right now. I mean, I hope there are some medications that are in the pipeline that I hope will be useful. The bottom line is that there's no well-studied medication for the use of methamphetamine, so we're left with the psychosocial treatments like cognitive behavioral therapy, like motivational enhancement, like family engagement, and also the adjunct treatments like NA and AA. I wish I had a better answer for you because I know how devastating the problem is, but as of now, there's no FDA-approved medication for methamphetamine.
Is there any psychiatric indications for a client who was dual diagnosed to be on this medication, as well as some psychiatric meds, either for schizophrenia, bipolar, or bipolar with psychotic features, or major depressive disorders?
Yeah, thank you for that question. So the question is, if someone's dually diagnosed, may they be on this medication as well as their psychiatric medication?
Yes.
The short answer is absolutely yes. That some patients are extremely well served by having their opioid addiction treated as well as their schizophrenia or their bipolar disorder, but they're not the same, obviously. Someone whose addiction calms down, they're no longer using heroin, that doesn't mean that their psychiatric symptoms are necessarily going to get better. So they're going to need to be treated also, to your point. So thank you. Both ends.
Got one.
Yep. Please. Yeah, so to paraphrase the question, how do you know if someone's right for it indefinitely, and how would you put someone on a titration plan? The way I usually know that someone should continue on their buprenorphine is that we attempt to taper them off and they have a slip or a relapse, and they start injecting heroin again, and their life falls apart. And so then, I try to set it up from the beginning that we'll taper you off this medication. If things don't go the right way, you should go back on the Suboxone. And usually people are deeply grateful in that circumstance. The other question, the corollary question was, how do you know when it's right to titrate somebody down? Frankly, I do that every time. When I start someone on this medication, the first thing out of the gate is not to put someone on a maintenance medication. I try to taper someone down, over 10 days or 14 days. We see how they do. And a lot of people do very well, actually, and get back to their lives and get back to their families, and at least as far as the time I monitor them, don't have any more slips with opioids. The other major indication is youth. I don't want to put a 17-year-old on a medication that he or she is going to need to take for the rest of their life. So I'm much quicker to taper down young people. quickly off Suboxone, probably in 10 to 14 days. I'm also extremely worried about overdose potential in young people because their judgment is not even as good as a 25-year-old, so they'll buy things on the street and do things to their bodies which no sane person would do. I'm very careful about those tapering downs, but youth will cause me to taper down more quickly. Yes? Oh, okay, right. I said that I cannot get high-end Suboxone, and then I said that most people who buy it on the street are getting it in order to treat themselves. If I said you can't get high in Suboxone, I misspoke. What I meant to say was that it's more difficult to get high on Suboxone than it is on heroin or even methadone. And I'm not saying people don't get high on Suboxone, and I'm certain there are people out there who have their first experience with opiates with Suboxone and probably could get high. And I don't doubt that there are some people who buy it as their drug of choice. It's very small, the number of people who do that. The second thing is I said that people who buy it on the street are buying it to get better. Is there any research on that? The answer is no. The concern I have is that a number of things have come out in the media, especially I believe from West Virginia, saying that their huge problem now with Suboxone, that people are buying Suboxone on the street, and that the law enforcement personnel worry that it's becoming a bigger problem than heroin or oxycodone and so forth. And I, like you, want to see some research and some data on that where we can see whether people are using it to treat themselves or whether they're using it to get high and selling it. Again, I can only speak from my personal experience and those of my colleagues. Everybody says that if you ask an addicted person, if you had a choice, what would you buy? Suboxone is way down on the list, okay? Not saying that you wouldn't do it, but it's extremely unlikely that you're going to do it. But we do need what you said. We need some data on this before we get into a situation where people are saying that maybe the cure is worse than the disease, and that would be a disaster if people are starting to think that Suboxone is more dangerous than the heroin or methadone use itself. So I don't think that's the case, but the reality is there aren't good numbers out there. We need to get good numbers. Please. Right. Thank you for that question. Thank you for pointing me in the right direction, too. I think that the first issue, not enough clinicians, is in the process of being addressed. There was a recent federal mandate to spend more dollars in this. Part of that included training more clinicians. The problem is that we're not getting clinicians to the right places. Frankly, in New York, we've got enough, actually. In areas where we don't have enough clinicians, we don't have enough training either. So I think what people of influence could do is push national organizations, including SAMHSA, including NIDA, including the American Academy, where I'm involved, and the American Society of Addiction Medicine, to have trainings in your area for clinicians. And I think once you get a group of clinicians who are knowledgeable about this medication and who are talking to each other, you'll get some who agree, some who disagree. You'll get some who say, in some circumstances, I might be willing to prescribe this. You'll get addiction counselors who say, once I heard this explained to me, I can see where some of my patients might benefit from it. And that's where we want people to be. I don't want people to be in a place where they say, well, everyone who uses heroin should just take buprenorphine. That's silly. We want people to be part of the mix and to understand there are some patients who will benefit from it. Other barriers, the cost, first of all, I think, the cost of pharmaceuticals is a problem that everyone grapples with in the field. I think pushing federal regulators to decrease price for Medicare and Medicaid is where we need to be on this. I think the people who use private insurance to pay for buprenorphine are relatively small. I think the larger issues are Medicare and Medicaid and getting people into those programs. So I appreciate your question, and I would like any assistance we can get in pushing the government to move these aspects forward. Other questions, concerns? I'm going to put my contact information up here, and I'd be happy to be in touch. And I want to talk about, if you want to learn more online, look at PCSS MAT. It's probably most useful for clinicians in the courts, but anyone can look at it. It'll give information about medication-assisted treatment. PCSL this is just about opiates. It's www.pcss.o.org. And again, I'll send these slides out if you don't get it down, and that's my information. So thank you very much for your attention today.